So a lot of folks come into our office with knee pain, and a lot of times, especially for some of our older individuals, a lot of that knee pain is on the medial side or on the inside of the knee where the other knee would kind of touch. So you have your outside of your knee here, you have your kneecap here, and then you have your medial side or the inside of your knee. Now this is just a side view of the leg and side view of the kneecap, etc. So when you get pain in this area here, there's usually, let's say 3 things that could be a problem. All right. First thing is going to be your MCL, your medial collateral ligament. Okay. So that's going to be out here. It's going to be very superficial. It's going to be out on the lateral side here. Okay. Now this isn't an always thing. There can be other issues, but usually it's going to be one of these 3. All right. So maybe you could rule out that medial knee pain. All right. So one thing is palpate, push on that medial knee. If you have pain and it's palpable and you can push on it, it's probably that ligament. If it's pretty superficial, probably. Now you shouldn't have to push very hard, and you should be able to recreate that fairly quickly. If it's very, like I said, it's got to be superficial. Now if you get a little deeper, have to push a little bit harder, and you feel like you're getting into a little bit more into that joint space, that could be knee inflammation, which could be pushing you towards, or you may already be at, arthritis of the medial knee. This is going to be the more common area that you get arthritis. That's why I say it's going to be sometimes, or you're at least starting down that road. That's the oh crap moment. Let's get in front of this. Let's not let this get massively bad. Get x-rays, have somebody who knows what they're doing look at this knee to figure out a game plan long term, not just a short term get out of pain. Put a steroid in there and cover your eyes, and then 5 years later you're replacing your knee because you didn't take care of the problem the way you could have. So that either, and then that medial knee space here, when you're bending the knee and you can feel right in that space, and you feel that's that same medial potential arthritic inflammation of the medial knee type of thing, because again you're going to see that joint spacing decrease many times, and then inflammation, bone spurring, etc., etc. The last thing could be, especially if you're a little bit younger, sometimes in the older age folks too, and by older age it is what it is. You figure it out as far as the actual number, but you could have some meniscus issues in there. So if you notice a lot of clicking, if your knee wants to lock on you, that could be more of a meniscus type of issue, which is the cartilaginous tissue that's kind of the cushioning tissue on the surfaces of the knee. So this is where you want to, if you start to feel that and it's real tender, but it's still, it almost, many times, and not all the time, but in that meniscus, it's going to be a little bit more anterior. It's not going to feel like it's real deep into that joint. It'll be like where if you dig a little bit in that soft, you can feel it. You can almost touch. It's like, ooh, that's the spot. That's the spot. And if it's there, it's probably your meniscus. Now, none of these have to be surgical if you treat them the right way and treat them aggressively. If you wait, put steroids, just take a bunch of over-the-counters and just try to manage it, you're going to end up setting yourself up for failure, because what's going to happen is you're not treating the problem, you're just covering it up. And if you don't treat the problem long enough, you're going to end up with severe breakdowns, severe arthritis potentially, and then it may be too late for you to get the care that you need and potentially avoid serious surgery, et cetera, et cetera. So